Today, I would like to talk to you about pain management in patients with liver disease. I have no financial disclosures related to this topic being discussed in this lecture. Chronic pain is common amongst those with liver disease. One study found that the prevalence of pain among patients with chronic liver disease was 70%, and the duration of chronic pain was significant with a mean duration of 6.7 years. The symptoms of pain was highest among those with hepatitis C, with a prevalence of 81% amongst those patients. In the VA population, 82.7% of patients with chronic hepatitis C reported symptoms of pain. 65% had chronic pain, which was defined as greater than 1 year. There are many forms of pain medications and interventions. For the purpose of this talk, these are the categories of analgesics that I will be discussing. Over-the-counter analgesics such as acetaminophen and NSAIDs, COX-2 inhibitors, antidepressants, in particular I will be discussing tricyclics, anticonvulsants such as gabapentin and Lyrica, topical therapies such as a lidocaine patch, and finally I will discuss opioid therapy. Drug metabolism largely occurs in the liver. There are several considerations in metabolism of any drug, many of which are affected by liver disease. I will go into greater detail about how liver dysfunction affects each of these aspects of metabolism in the next few slides. The first consideration is first-pass effect. After a drug is swallowed, it goes through the GI tract, then through the portal vein into the liver, then enters the systemic circulation through the hepatic veins. The proportion of the drug that actually enters the systemic system is what is considered bioavailable. Therefore, after hepatic metabolism, only a portion of the drug is actually bioavailable. In patients with healthy livers, drugs with a high first-pass effect have low bioavailability. However, in patients with liver dysfunction, drugs with first-pass effect have increased bioavailability, which increases risk of toxicity. Another liver-related issue involved in drug metabolism involves mechanism of metabolism. Some drugs are created in parent form and need to undergo phase 1 metabolism to create the active metabolite. Phase 1 metabolism involves reactions such as oxidation or reduction by hepatic enzymes, including the cytochrome P450 family of enzymes. The main function of phase 1 metabolism is to prepare the parent drug to be in the correct chemical state so that it can undergo phase 2 metabolism and subsequent excretion. Phase 1 metabolism is highly affected by liver disease. Phase 2 metabolism involves conjugation with a chemical group and includes reactions such as glucuronidation. Phase 2 metabolism is less affected by liver disease. In the blood, a drug exists in two forms, bound and unbound to plasma proteins. The bound form is considered inactive. The unbound form is active and is able to be metabolized and excreted. Albumin is the most common plasma protein used for drug binding and, as you know, is made by the liver. There is a decrease in serum albumin in liver disease. Therefore, there is more unbound drug, which increases the risk of drug toxicity. Therefore, drugs that are highly bound to protein will have higher levels in patients with liver dysfunction. After a drug is metabolized, the active metabolite enters the systemic circulation for action, then must be excreted. The kidneys are the principal organ that handles drug excretion. Many patients with advanced liver disease have impaired renal function. Therefore, drug excretion is impaired, once again increasing risk of drug toxicity. It is important to note that altered drug metabolism only occurs in patients that have significant liver dysfunction. This slide demonstrates the spectrum of liver dysfunction, which is important when considering how a drug is affected by liver disease. On the left, patients with no liver disease or asymptomatic chronic liver disease without cirrhosis such as fatty liver disease or chronic hepatitis C, have preserved liver function, and therefore drug metabolism in the liver is not affected. However, as seen on the right side of the red line, patients with symptomatic advanced liver disease without cirrhosis, such as alcoholic hepatitis or acute liver injury, as well as any patient with cirrhosis, have significant compromise in liver function and are therefore at greater risk of drug toxicity due to alterations in hepatic metabolism. For the purpose of this talk, the conditions that are on the right side of the red line will be called diseases with liver dysfunction. It is important to note that there is a lack of large prospective studies on drug metabolism, toxicity, and clinical efficacy in patients with liver disease, excluding that of acetaminophen, which is well described. As a result, no true guidelines exist regarding the use of analgesics in this population. The recommendations that I've included in these slides are based on a review of the literature. The other thing it is important to note is that if narcotics are being considered, it is very important to balance the risks versus benefits, and I will discuss this in future slides. The first analgesic that I will discuss is acetaminophen, which is also known as Tylenol and paracetamol. It is a common misconception among patients and physicians that all patients with liver disease should never take Tylenol. This is largely because when ingested in large amounts, usually doses greater than 10 grams per day, it can cause severe hepatic necrosis and fulminant hepatic failure. In this setting, it is the most common cause of acute liver failure in the United States. Annually, overdoses are responsible for 56,000 emergency room visits, 26,000 hospitalizations, and 458 deaths. However, acetaminophen is a safe and effective analgesic in patients with liver disease as long as the dosage is limited. In fact, in patients with cirrhosis, acetaminophen is actually a safer analgesic than NSAIDs. Therefore, the dosage should vary based on the severity of liver disease. In patients with asymptomatic liver disease, dosage should be limited to 4 grams per day. In patients with advanced liver disease or cirrhosis, dosage should be limited to 2 grams per day. And in any patient with active alcohol abuse, dosage should be limited to 2 grams per day. So back to our diagram, if you're on the left of the right line, meaning you have preserved liver function, once again, acetaminophen dosage should be limited to 4 grams per day. On the right side of the line, which represent patients with significant liver dysfunction, dosage should be limited to 2 grams per day. And then on the bottom, I mentioned that in any patient with active alcohol abuse, dosage should be limited to 2 grams per day. And it is also important to remember that many over-the-counter products contain acetaminophen, such as NyQuil, Alka-Seltzer Plus, Theraflu, and obviously Tylenol Cold and Flu. Patients should be educated that many narcotics also contain acetaminophen as well, such as Percocet, Vicodin, and Norco. Most of these medications contain approximately 325 milligrams of acetaminophen per tablet. Therefore, Percocet, Vicodin, and Norco should be limited to no more than 6 total tablets per day, and patients should be educated that they should not take additional over-the-counter Tylenol products if they are taking these kinds of narcotics. NSAIDs are a class of analgesics that inhibit production of prostaglandins and thromboxanes. Prostaglandins protect GI mucosa from noxious agents such as gastric acid. It also serves as a vasodilator. Thromboxanes assist with platelet aggregation and hemostasis. Therefore, using NSAIDs in patients with liver dysfunction can cause increased risk of bleeding from either varices or peptic ulcer disease, especially in patients that have underlying thrombocytopenia and coagulopathy. NSAIDs also increase the risk of acute renal failure due to decreased renal perfusion, and this can be via a mechanism of hepatorenal syndrome or acute interstitial nephritis. In one study, patients with cirrhosis that were given 50 milligrams of indomethacin every 6 hours for just 1 day had a 19% reduction in GFR, 23% reduction in renal plasma flow, and a 29% increase in serum creatinine. COX-2 inhibitors, such as celecoxib, are associated with decreased gastrointestinal and renal toxicity. However, the experience in patients with advanced liver disease is limited. Due to risk of cardiovascular events and lack of robust data, most experts avoid the use of Celebrex in patients with cirrhosis. Antidepressants are another class of analgesics that are well reported in the literature to be used for pain. I will focus on nortriptyline, which is believed to be a better choice than amitriptyline. Nortriptyline does have extensive first-pass metabolism, and it also has dose-related anticholinergic effects, such as confusion, sedation, dry mouth, and constipation, and it also can have significant cardiovascular effects. All of these side effects could be poorly tolerated in patients with advanced liver disease or cirrhosis. Therefore, if nortriptyline is chosen, it should be started at a low dose, such as 10 milligrams QHS, and slowly increased as needed over weeks to a goal of approximately 25 to 50 milligrams. Anticonvulsants are also used for pain, and I will focus on gabapentin and pregabalin. Gabapentin, which is also known as Neurontin, is not metabolized by the liver, is not bound to plasma proteins. It is renally excreted, so does need to be dosed in patients with liver disease and renal failure. And starting dosage should be approximately 300 milligrams daily and increased slowly over weeks. Similarly, pregabalin, which is also known as Lyrica, is not metabolized by the liver and also not bound to plasma proteins. Similar to gabapentin, it is renally excreted, so dosages do need to be reduced in patients with liver disease and renal failure. Dosage should start low at 50 milligrams twice daily and can be increased slowly as side effects tolerate over weeks. Finally, there are some effective topical therapies that can be used for pain in patients with liver dysfunction. A lidoderm patch does have low systemic absorption through the skin, and no adjustment is needed for liver dysfunction, so this is a very attractive form of therapy for musculoskeletal pain in patients with liver dysfunction. Opioids should be used with caution in patients with liver dysfunction. Opioids can induce or worsen hepatic encephalopathy, and they can also create dependency, especially in patients with a history of substance abuse. It is also important to note that many transplant programs will not transplant a patient or list a patient that has a history of alcohol or substance abuse who is currently on narcotics. So when it comes to prescribing an opioid, if this is in fact what your patient does require, it is difficult to know which is the best opioid to use. Each is a little different. Some have a high first-pass effect, some are highly protein-bound, and most are metabolized by the liver. Therefore, in patients with liver dysfunction, they will have an increased bioavailability and or decreased drug clearance. So it's really not clear which of the opioids are the safest, most effective, and the least addictive. However, based on the review of literature, there are some that are believed to be a little worse for patients with liver dysfunction and some that are believed to be a little better, and I will go through these in greater detail. Of the opioids that are believed to be a little bit worse in those with liver dysfunction, the first I will discuss is morphine. Morphine undergoes glucuronidation, which is phase 2 metabolism, which is usually not as highly affected by liver dysfunction. However, due to high first-pass metabolism, the half-life of morphine is doubled in patients with advanced liver disease or cirrhosis, with a half-life going from 3.3 hours in patients with normal livers to 5.5 hours in patients with liver dysfunction. More importantly, the metabolite that is formed by metabolism of morphine is highly toxic to the CNS and can result in seizures, respiratory depression, and hepatic encephalopathy. And this metabolite is also poorly excreted in the setting of renal insufficiency. So overall, it is probably best to avoid morphine in patients with cirrhosis and renal failure. Codeine is an analgesic whose effects are believed to be due to conversion to morphine. Therefore, codeine is plagued by the same problems as described above for morphine and undergoes the same cautions, especially in patients with cirrhosis and renal failure, as described previously. Meperidine undergoes phase 1 metabolism to normeperidine, which is a toxic metabolite responsible for neurotoxicity and is especially toxic in patients with renal insufficiency. Meperidine is also heavily protein bound, which increases its bioavailability. Overall, meperidine should be avoided in all patients with liver dysfunction. Finally, hydrocodone and oxycodone undergo phase 1 metabolism to the active compound, which is hydromorphone and oxymorphone, respectively. In patients with liver dysfunction, hydrocodone and oxycodone have a significantly prolonged half-life. Specifically, oxycodone increases from a half-life of 3.4 hours in patients with a healthy liver to 13.9 hours in patients with liver dysfunction. These medications also have variable efficacy in patients with liver disease. Next, I will review a few of the opioids that are believed to probably be a little better tolerated in patients with liver dysfunction. Fentanyl undergoes phase 1 metabolism into an inactive and non-toxic metabolite. The pharmacokinetics and half-life is similar to those with a normal liver. There is no associated histamine release with fentanyl, therefore there's less hemodynamic disturbance than other opioids, and fentanyl is less affected by renal failure. It is highly protein bound, therefore fentanyl dosages do need to be reduced, and we usually recommend 50% reduction. Hydromorphone undergoes phase 2 metabolism and therefore is not as highly affected by liver dysfunction and creates an inactive and non-toxic metabolite. It is also less affected by renal failure. However, it is important to note that hydromorphone is 5 times more potent than morphine, and this really does need to be considered, especially in patients with a history of substance abuse. Methadone is a long-acting opioid. The pharmacokinetics of methadone is similar amongst those with normal livers and those with liver dysfunction. It is highly protein bound, therefore dosage does need to be reduced in patients with liver dysfunction. Overall, methadone is believed to be safe in patients with liver dysfunction, and especially among those with heroin dependency, the benefit likely outweighs the risk. Tramadol is an opioid that undergoes phase 1 metabolism. It does have a prolonged half-life in patients with liver dysfunction and is known to have variable efficacy. It is important to note that tramadol can lower the seizure threshold, so should be avoided in patients with liver dysfunction and underlying seizure disorder. So in summary, if opioids are needed, these are the ones to consider. Hydromorphone, 1 milligram PO Q4 hours. Fentanyl, 12.5 micrograms topically, Q72 hours. Methadone, 2.5 milligrams, Q8 hours. Or tramadol, 25 milligrams, Q8 hours. However, it is of utmost importance to be carefully monitoring the side effects of these opioids. In particular, due to prolonged half-life and increased bioavailability, these opioids can result in increased sedation. Constipation is common with opioids. However, in patients with liver dysfunction, this can precipitate hepatic encephalopathy as well as hospitalizations due to encephalopathy. Therefore, it may be important to consider prophylactic laxatives such as Miralax if this patient is not already on lactulose for hepatic encephalopathy. And of course, it is important to remember the potential for dependency and addiction, especially in the setting of patients that have a history of substance abuse. So here are my take-home points regarding pain management in patients with liver disease. Acetaminophen is a safe and effective analgesic in patients with liver disease as long as the amount is limited. In patients with asymptomatic liver disease, dosage should be limited to 4 grams per day. In patients with advanced liver disease or cirrhosis, dosage should be limited to 2 grams per day. And in any patient with active alcohol abuse, dosage should be limited to 2 grams per day. The use of NSAIDs is okay in patients with asymptomatic liver disease, which includes conditions such as fatty liver disease or chronic hepatitis C without cirrhosis. However, in patients with advanced liver disease or cirrhosis, you should never use NSAIDs due to increased risk of GI bleeding and the potential for precipitating acute renal failure. Nortriptyline is an effective antidepressant for pain. However, dosages should be started low at 10 milligrams QHS and increase slowly over weeks to a goal of 25 to 50 milligrams QHS. Neurontin and Lyrica are effective anticonvulsants for pain. Neurontin should be started at 300 milligrams daily and increase slowly over weeks. And Lyrica should be started at 50 milligrams twice a day and once again increase slowly over weeks. For musculoskeletal pain, a 5% lidoderm patch is very well tolerated among patients with liver dysfunction. Finally, opioids should be reserved if all other interventions fail. In patients with liver dysfunction, dosages of opioids should be reduced and an increased dosing interval should be implemented. And it is very important to carefully monitor side effects such as oversedation, constipation, and risk of dependency in patients with liver dysfunction. Thank you very much.